Hello, dear students and esteemed learners. Welcome again. This is lecture number 35, and today we are going to cover the topic National Rural Health Mission, National Urban Health Mission, and the National Health Mission. As you may remember, we are talking about the larger theme, which is healthcare structure and major health programs in India. So, from sociology of health perspective, we are trying to understand that how in India a specific kind of healthcare structure developed and how the people are getting benefited by the health services, and then what are the achievements, and then which other agencies or institutions basically are contributing in the emergence of the healthcare services, and so many other related things. And the government run programs are very important in this because the government is playing the most important role in ensuring health services in India. Although we have seen that as of now in the contemporary Indian society, the share of the government in the total health expenditure is uh, much lesser. The private sector is basically taking the lead, and most of the expenditure is actually the out of pocket expenditure. But we will try to understand these things at a later stage when we will have a specific topic on that. As of now, we will try to understand two very important health programs which have given shape to the health system in India, and that is the National Rural Health Mission, and at a later stage, the National Health Mission. In between, we also have the National Urban Health Mission, but basically, when we had the National Urban Health Mission, then that was superseded by the National Health Mission because that was taking care of both components. We will talk about that. However, there is a very important role played by NRHM in giving shape to a specific kind of health structure in India. Soon we are going to see that. In this lecture, I have tried to cover all these three subcomponents which are already there in the topic. So directly we can go to our first slide. So the National Rural Health Mission, as it is self defined, that it is going to talk about the healthcare facilities in the rural India. And why did the government uh, have this program? Because the government realized that the people in rural areas are not getting the kind of health facilities that they should have. The rural areas were marginalized, the people were vulnerable, and we have already seen that good number of disease control programs and then vaccination and immunization programs were running. So the reach of those programs were generally remaining confined to the urban areas. The benefits were not reaching to the rural population because of so many constraints and difficulties. So with this kind of realization, the NRHM came into existence way back in 2005. The Government of India, Ministry of Health and Family Welfare, launched the National Rural Health Mission in 2005. Then this NRHM recognized the importance of health as contributor of social and economic development. We have already discussed social development and economic development. So this NRHM basically says that health is a contributor in both. And then at a later stage, we have also seen that health is very important for human development also. However, the government generally think of economic development. So the moment the government has realized that health is an important component of economic development also, so uh, they took a specific mechanism to support that. And then the social development aspect is very important, because as we have discussed earlier, that there are some kind of disparity existing. And we have been witnessing or experiencing the disparities existing even in the health outcome. The disparity existing at the level of the gender, then at the level of the states. So there were concerns from the social development perspective also. And so this basically good idea, good sense prevailed, that health is a contributor in the social as well as economic development. And then this NRHM adopted the synergistic approach by relating health to the determinants of good health. And the determinants of good health are basically many. These are actually the social determinants that we have already discussed multiple times, like sanitation, nutrition, safe drinking water, etc. But now we have been talking about these things at the theoretical level, or at the philosophical level, or at the level of the recommendations. But now in the NRHM, we can see that all those theoretical or philosophical things are getting translated into action. These are getting executed. So NRHM believes in the significance of these social determinants, and it takes into consideration all these social determinants. And so it says that it intends to provide the accessible, affordable, accountable, effective, and reliable healthcare to rural population. Now, one more thing is important here, that way back in 1993, in India, we had the 73rd constitutional amendment, right? And with that, basically, the Panchayati Raj institutions got strengthened. So now at all India level, we are having the Panchayati Raj institutions. That means the Gram Panchayat, the Panchayat Samiti, etc. Right? So this National Rural Health Mission is intending to have some kind of interconnectedness with the functioning of the Panchayati Raj institution, so that there can be a democratic participation of people in the health building process, right? So as we discussed in the previous lecture, basically it also depends upon the nature of the society, that what kind of healthcare system it will have. So because India is a democratic society, and now we are having the Panchayati Raj institutions, and so we are having this National Rural Health Mission. And because of the kind of democratic system, this program was supposed to take care of the health related needs of the population at a larger level. Then the core strategies are mentioned here. To train and enhance capacity of Panchayati Raj institutions in order to own, control, and manage the public health services. So now the Panchayati Raj institutions are basically functioning at the level of the political and the social requirements, right? So they are not having the kind of understanding that how can they make some kind of intervention in the domain of healthcare, right? So they need some kind of capacity enhancement and training. So that is one of the functions or the requirements. Then basically accredited social health activist, that is also known as ASHA, that is a new health activist that was introduced under this NRHM. And the ASHA were supposed to help the women to undergo the institutional deliveries, because maternal mortality is one of the serious problems which is prevailing at the grassroots level or the rural level. So, a new health activist was also envisaged through this NRHM. And then another important thing is the village health committee. Initially, NRHM talked about village health committee, but later on it talked about village health and sanitation committee, and finally village health, sanitation and nutrition committee. This will be a committee which will take care of the health, sanitation and nutrition level requirements of people, again at the grassroots level. So because this committee will engage local people along with other functionaries, so they can supervise what is going on at the level of sanitation or nutrition, and then they can make some kind of meaningful intervention also. So these are very important things which were initiated. And then strengthening these sub centers, we have already talked about these sub centers in the previous lecture. So some kind of strengthening was required so that it can function appropriately, and the ANMs are also associated with the sub centers. So a kind of effort was required so that all these sub centers or primary health centers or the panchayati raj institution can work together to achieve the targets related to attainment of health for all, and NRHM primarily believes in that. Then there were supplementary strategies also. And what are some of those supplementary strategies? So to regulate private sector, including the informal rural practitioners. Now we have stated that in the rural areas there were not enough number of health service provider or the professional uh, medical care provider like the doctors. So in the absence of those practitioners, basically in the rural areas, there was the practice of having informal rural practitioners. Sometimes that is also identified as quacks. Sometimes we have the people who have some kind of understanding about the medicines, and then they are running their own clinics which is not registered and which is basically illegal also. But because of lack of medical practitioners or professional practitioners, there was prevalence of that kind of things. So some kind of regulation was required at the bottom level as well as at the larger level in which the private sector is operating. Then to ensure availability of quality services to citizens at the reasonable cost. So when you are having the private sector, then those services should be affordable, and at least a reasonable cost should be taken care of, right? So there were several other things. And then there is another very important thing which is public private partnership. So NRHM basically created a kind of trajectory in which the public and private partnership also developed. That means often the government system will take support from the private system also, and the goal of health for all is required to be achieved through this kind of partnership. That means the private practitioners, the contribution of the private practitioners is also acknowledged, that they are serving and they are helping people to reach to their health needs. And then there is another important thing which is basically mainstreaming of Ayush. So we have seen in some of the previous lectures that earlier Ayush was basically a department at the union ministry level, and then later on it became independent ministry. So there was efforts to mainstream the Ayush practitioners, and this NRHM way back in 2005 talked about mainstreaming Ayush. And then there is another important thing, that at the level of the primary health centers, there is a if the state government is basically making the provision, then they can also appoint the qualified people from the Ayush system also, just like the biomedical system. So that will depend upon the specific rules and regulations that the state government is having, or for that matter the central government is having. But NRHM basically is tried to mainstream the Ayush system, and then reorienting the medical education to support rural health, and then pooling and social health insurance. Social health insurance is again very important thing, because without some kind of health insurance, people were witnessing huge devastating impact of the high cost of healthcare in the private sector. So with this kind of understanding, the NRHM became very successful. Initially, it was planned to operate from 2005 to 2012, and so it was functioning very well, and the primary health sector got strengthened, and we have made several achievements. But we are not talking about an assessment of the NRHM as of now. We are trying to understand the system. So we will talk about the another important program here, and that is the National Urban Health Mission. Now, this is a sub mission of the National Health Mission, and this was basically approved by the cabinet in 2013. So, NRHM started from 2005 and it ran till 2012, and then it was continuing, and it was also realized that the rural people are getting benefited by the NRHM, but the urban people and at least the poor and the vulnerable are not getting benefited by that kind of program. So the government realized that parallel kind of program should be there for the urban poor also, and so this National Urban Health Mission got started. It envisaged to meet healthcare needs of the urban population with the focus on urban poor and slum dwellers by making available to them essential primary healthcare services and reducing their out of pocket expenditure. So, two things basically we are talking about. One is the accessibility of primary healthcare, because when people are in distress, they need some kind of healthcare facility immediately, and primary health centers actually help them because these are available in the vicinity, in the locality in which people are living, right? So they can get any kind of immediate support at the level of the primary health centers. And the second thing is this, that because of the high cost of the private healthcare, the poor people are having huge out of pocket expenditure, and that is creating the catastrophic impact. So the extension of the National Urban Health Mission to the urban poor will definitely bring them all the benefits of this program. And with this kind of understanding, this program was started. Then it intended to achieve several important things like strengthening the existing healthcare service delivery system in those areas, then targeting the people living in the slums, and then converging with various schemes relating to wider determinants of health like drinking water, sanitation, school education, etc., which were implemented by the separate ministries. That means playing an important role in ensuring the services which we generally identify as public health services: drinking water facility, then nutrition facility, then facilities related to food. But because the public health facilities are generally remaining confined to the specific areas within the urban municipal corporations, but the slums or the jhuggi basti or other areas where people coming from very poor section are living, in those areas are generally beyond the municipal corporations area. So the benefits of the facilities which are basically organized by the municipal corporations are not reaching to those areas. So National Urban Health Mission is extending some of the necessary services at that level too. And then we need to talk about the National Health Mission, because when we have this National Rural Health Mission and simultaneously we also have National Urban Health Mission, that means the mission is taking care of the rural as well as urban people, and so there is no need of making a kind of exclusive approaches. Although this is just to make you understand that kind of thing. The NHM, that is the National Health Mission, came into existence in 2013, and the National Urban Health Mission also came into existence in 2013. So as of now, within the National Health Mission, these two programs, National Rural Health Mission and National Urban Health Mission, are operating as per the information available in most of the government websites and the research papers. Now, why I'm saying this? Because very often some of these programs, because in the health sector we are having multiple programs, and I'm telling you time and again that it is very difficult to have a fair understanding about all these programs, because there are good number of programs and some of these programs are actually intersecting each other. So very often you may have a kind of confusion about which of these programs are actually operational or non-operational, because one specific program may be operational in one specific context and not operational in another specific context. So programs are basically meant for a specific time period, right? This is something that we need to understand. When you are talking about the structure, then the structure is basically existing for a longer period of time. But when you are talking about a specific program, then that is operating for a specific time period. So you always need to verify whether that program is running in that time period or not, right? And I don't know when you are hearing this lecture basically, right? So always try to verify from the websites, the government websites, whether the programs that we are talking about in this lecture are operational at that point of time or not, right? But as of now, we are trying to understand those so that we get a good idea about what kind of initiatives are taken by the government and what kind of structures are basically coming into existence, and how the health related needs of people are getting fulfilled, right? So this much of theoretical understanding is always required when we deal with this type of issues which are very contemporary. Now, the National Health Mission envisages achievement of universal access to equitable, affordable, and quality healthcare service that are accountable and responsive to people's needs. So, there are all great things stated here. The main programmatic component of National Health Mission include, so basically when you talk about National Health Mission, that means there are three core domains. One, the system strengthening, that means the kind of structures which were existing. We talked about the primary health centers and the sub centers and the community health centers, and NRHM has played a very important role in strengthening those centers and making those visible. The vision document of NRHM says that making primary health centers visible. So strengthening this system is very important target. Then second very important component is the reproductive, maternal, neonatal, child and adolescent health, RMNCH plus A, right? So this is the reproductive, maternal, neonatal, child and adolescent health, and this will take care of the health of the reproductive women, then the maternity experiences, then the newborn, that is the neonatal, and then the children, and then the adolescent. That means from newborn to adolescent, and then when women enter into the reproductive age, and then the maternity related experiences, because these are all very sensitive and these are all related with not only the present but also the future. These are very important. We have talked about these things in the millennium development goals and also in the sustainable development goals. So why did we talk about the millennium development goals and sustainable development goals? So that we can get to know that how the topics identified at that level are basically getting converted into or getting translated into the programs that we implement at the national level, right? So now the National Health Mission has already included all these goals which were basically categorically identified by the Millennium Development Goals and the Sustainable Development Goals. So these are the two very important domain in which NHM is working, and the third domain is control of the communicable and non-communicable disease. We have already talked a lot about that. We had one lecture on disease control programs, and there we realized that there are good number of disease control programs in India which are actually in operation as of now, and these need to be very functional, very productive. Why? Because there are good number of diseases which have not been controlled till now. So although we intend to control the spread of those communicable disease and then finally eradicate them, but till now we have not made big achievement, and there are good number of. So all these kind of program, whether related to the controlling of the communicable disease or the non-communicable disease, or you are talking about the health of the neonatal or children or adolescent or mother, all these things have been covered by the National Health Mission. That means everything related to their operationalization, everything related to their making these programs result oriented, productive, and above all executing these programs, all these things are actually uh, being taken care of the modalities developed by National Health Mission. Of course, the various health agencies are involved in this, and that is why we have already discussed the existing health system and health structure also. So, at the state level, the mission functions under the overall guidance of the state health mission. So, at the national level, we have the national mission, and at the state level, we have the state mission, and this is functional at that level also. Then we have very well defined goals under the National Health Mission. We can have a look on these goals: reduce maternal mortality ratio 1 to 1000 live birth, then infant mortality rate 25 to 25 per 1000 live birth, reduced total fertility rate 2.1. Now, why do we talk about 2.1? This is total fertility rate at 2.1 is considered as a stabilizer, right? So, when a nation state is achieving the fertility rate of 2.1, then this is considered as that the population will remain stable. It will not increase or it will not decrease, right? Because both the problems are very severe. The declining population is one of the serious problems in many of the European countries. So, just to avoid the declining population, 2.1 is considered the appropriate TFR. Prevention and reduction of anemia in women aged 15 to 49 years. So, we have seen that to what extent anemia is prevailing in India, and what kind of disparity is existing among various states. So, these are very important goals and targets. And then there are several other which are related to the control of a specific disease, right? So, this way, important goals have been identified for NHM, and these are basically getting delivered also. Before we close, we need to talk about something related to the specific components of the National Health Mission that we just discussed. This reproductive, maternal, newborn, child, and adolescent health. This is a very comprehensive strategy, and it is getting operationalized through multiple programs. We'll talk about all those programs separately in one of the lecture. There we will cover the reproductive health, because we need to understand first what is reproductive health and what kind of intervention is required, and then only we will talk about the schemes or the programs which are supposed to achieve the specific targets. Understanding those concepts are very important. And then non-communicable disease control program, we have already discussed many of these programs, so you have a fair understanding. Then the communicable disease control program, you already have some kind of understanding about that. And then the system strengthening approach, because basically we are talking about health system, and unless we develop a viable strong health system, we cannot think of delivering the kind of services that people need, because the needs and requirements of people keep on changing, because the health needs are not static, these keep evolving. Nobody could have thought of 5 years before that we'll have something like COVID in 2019, which devastated the health structure at one point of time. So, disease, and especially the communicable disease, create unforeseen challenges. We need to develop structure, system, mechanism, so that when required, we can provide the necessary services at a viable level. So, NRHM and National Health Mission is one such major step which has strengthened the health system in India. So, with this, we close this lecture, and this is the last lecture of this week also. So, I hope by now you have understood the health system, the healthcare system, and some of the important health related programs, and overall the kind of interconnectivity of the immunization program, then disease control program, and then primary health care, and other things that we have discussed. So, take care. We will meet in the next class.